Okay, thank you very much. Wow, Dr. Your presentation is already all include mine. So yeah, thank you for the opportunity. My topic today is about the relationship between lupus and tuberculosis. And I would like to share some experience of our center. So before start, I would like to show you, this is our lupus study group. We have a small lupus study group. We meet each other every Thursday in Immunology Study Center in 5th floor, Ekman Building in Bandung. You were all welcome, but during pandemic, we meet virtually every Thursday. So whenever you have any idea on lupus studies, so you are always welcome. So this is our fishbone of lupus study group. We done so far from 2013 until now. We built a lupus Hasan Sadikin lupus registry. Then we put all our lupus patient here, and to find the way of better quality of life of our patient. So we done a study in genetic, epidemiology, also diagnostic study. We collect all the manifestation and also the comorbid and include tuberculosis, which I will discuss with you today about all our study here. And from this small lupus study group, we have published about 50 publications nationally and internationally journal. So from our lupus collaboration, we already work together with all many center in Asia Pacific here, if you can see. Then we also work together with the University of Santo Thomas collaboration in lupus study, as well as in KO University. And currently, we also work with the center in Netherlands and also in New Zealand. So from that, we are interested in the SLE and tuberculosis. Then we have done several study of this and also published together with Dr. Atik and also with the Dr. Ediana and some publication in the future. So this is my outline for today. So I would like to discuss with you the risk, genetic role, as well as the manifestation of TB in SLE, and do we need the INH prophylaxis? So my first talk about the risk. So before that, I would like to show you that based on WHO publication, they mentioned that around 8.9 to 11 million people in the world that suffer from tuberculosis in 2019. And most of them is in Asia, if you can see here. And the two-third Asian cases, it's from Indonesia and also from Philippines. So we are the country with the many cases of tuberculosis. So it also impact to our lupus patient. So being a lupus patient themselves is already a risk for developing tuberculosis, as well as in using prednisolone and immunosuppressant, as presented by Dr. Navarra a while ago, that is already a risk for developing tuberculosis. Like one study in Taiwan showed that 4.9 times. And based on the study showed the prevalence of tuberculosis in SLE is quite high. It's around 5 to 13.7%. It's higher compared to common population is about 0.9%. So it's quite high. And the incidence rate is range from 150 to 2,450 per 100,000 patient years. So it's quite high. And for this, I would like to show you our registry study. We collect the data of our patient using the red cap, and then we publish it in the Lupus Journal in 2019. And from this study showed that in total 813 patients we collect from 2008 to 2017. Then we found out that 93 of them, or 11.4%, developed tuberculosis after they diagnosed as SLE. So it's quite high. So from that, we look for what is the risk factor actually. And this is one we use, we have done literature research, systematic literature review on what is the risk factor actually for the tuberculosis in SLE patient. So we found out this high disease activity with SLEDAI more than 12, the renal involvement, high cumulative doses of glucocorticoid, lymphopenia, longer disease of duration of SLE, as well as the past history of tuberculosis are the risk factors of SLE patient to develop tuberculosis. So for this, we have done another study, the cohort study, collect all the data of our patient, include 1,278 patients from the first we opened our registry until December 2020. Then we found out we have 131, so about 10.3% of our lupus patients develop tuberculosis after they diagnosed as SLE, and 7 of them has 2 episodes of tuberculosis. So for this, we counted this 2,873 cases per 100,000 person years. So compared to other study, like here include the study from UST Philippines and also study from India. Here, then the highest number is 2,450. So it means that in our cohort, we have more developing tuberculosis in our patient. So it's really pay attention for this. So this is unpublished, but soon we will submit this paper. But I would like to show you, we use the Cox regression multi-analysis. We can see here that household contact and methylprednisolone pulse and using of corticosteroid increase the risk of developing tuberculosis in our SLE patient. The hazard ratio ranges from 1.97 to 17 if they use the corticosteroid. And interestingly, like Professor Navarra mentioned a while ago, the using chloroquine or hydroxychloroquine can decrease the risk of developing tuberculosis. It's very interesting. So means that the chloroquine has a protector to tuberculosis also. And by the literature show that if you use the glucocorticoid, it's an increase the risk, and the higher dose of corticosteroid also increase the risk until 7.7 times compared with them without the glucocorticoid. And based on one study done in Hong Kong, show that 23% increase the risk of tuberculosis in each gram cumulative of dose of steroids. So corticosteroid has a role, important role in developing or tuberculosis. So is the genetic have a role in developing a TB in SLE patient? As presented a while ago, the genetic susceptibility always has a role in developing of autoimmune disease. But based on the other studies show that in developing tuberculosis, beside the Mycobacterium tuberculosis itself, the genetic has also the role in developing manifestation of tuberculosis. So in the all kind of genetic that is already mentioned here, some of them is similarity to lupus. And we can see here the VDR, the vitamin D receptor gene, it also has the same role in developing tuberculosis as well as SLE. So here the meta-analysis done by Aresi et al. Show that polymorphism, the BSM1 from VDR receptor gene polymorphism, show that even it's not in overall population, but the BSM1 has increased the risk of pulmonary tuberculosis in Asian patients. So in the other meta-analysis show that in FOC1, polymorphism gene VDR receptor has a role in the developing of tuberculosis in Asian population, but not in Caucasian and African. So for this, we conduct also the study. This just presented orally in the last APLAR meeting in Kyoto, that we try to look for the risk of vitamin D receptor gene polymorphism as the risk factor for developing tuberculosis in our lupus patient. We use the restriction fragmented length polymorphism to see the VDR BSM1 and FOC1. And we found out in BSM1, we cannot see any difference between the SLE patient with or without TB. But in FOC1, we can see here, we can find out there is significantly increased the risk of developing tuberculosis, as well as in the allele and genotype FOC1, as well as in dominant model. So FOC1, as a conclusion that FOC1 has a role in the increase the risk of developing tuberculosis in our SLE patient. Another study done that we do another genetic screening for NAT2 or N-acetyltransferase 2 acetylated status among our lupus patient. We found out most of our patient has intermediate and slow acetylated status. So it means that whenever they develop tuberculosis, it's very important to see their acetylated status because it's related with the INH induced the liver toxicity. So how to differentiate the TB among SLE? This is challenging because based on this study, we can see that several studies show that extrapulmonary tuberculosis is quite high among our lupus patients. Yeah, range from 44% until 73%. So the extrapulmonary is related to the mortality of the TB. So, and it's quite high compared to other population. And as clinician, we most of the time it's very challenging to diagnose our patient. Is it tuberculosis or is it lupus? Or maybe our lupus patient developed tuberculosis because they share the same manifestation like prolonged fever, cough, hair loss or weight loss or sweating or lymphadenopathy. Most of the time we found out our patient with that things. And also the arthritis, sometimes the aseptic meningitis or with the tuberculosis meningitis. So it's quite difficult to differentiate this is the TB itself or SLE with the tuberculosis. Some parameter can be used like AFB smear or a rapid molecular test or culture to find the definite or even the high histopathologic can make our diagnosis sure. But whenever you use the autoantibody, it's quite difficult because based on the study show that in tuberculosis, it's developed around 32 to 50% ANA positive in lupus patient. So this is study from a group in Taiwan. They tried to look for the autoantibodies in the TB patient without the autoimmune disease. If you can see here, the anticardiolipin is a higher compared with the normal population as well as anti-SCL70. So means that if you have a TB patient, you must be careful because their antibody can also be positive. So as Professor Navarra has already mentioned that besides the genetic susceptibility, whenever the infection can trigger the autoimmune disease, and TB is one of the infection can trigger also the autoimmune disease because whenever develop the tuberculosis, we can see the autoantibody increase in this patient. But is the tuberculosis can also trigger the patient with the susceptible gene develop SLE? Is one of the question which need further study, but based on the paper say that mycobacterial intercellular 70 kilodalton hit as a protein can trigger the development of the autoantibody. So maybe in the future we can find out the proof that beside the EBV, like Professor Navarra has already presented, that viral like HSV or ABV is a trigger of the developing SLE. And maybe in the future, we can see that maybe TB is also one of the trigger to develop tuberculosis. So from our cohort, we collected that the tuberculosis already happened in our cohort is about 8.8%. They developed tuberculosis long time prior to develop SLE, and 18 among them also developed TB after they diagnosed as SLE. This one is need a further study. That is it possible that TB also increase the risk of the developing of SLE. So the next problem is how to diagnose, if it's possible to use the IGRA, the interferon gamma release assay. This is the T cell of the individual who have acquired a TB infection in the past previous, and will respond to the re-stimulation with MTB specific antigen by screening the interferon gamma. Based on one study in Japan mentioned that they can use the IGRA to diagnose a latent and active TB. However, in TB patient with the active SLEDAI and also the lymphocytopenia, make this test is indeterminate. So we also conduct study by the group of Dr. Atik and Dr. Winnie here, also in, among the participants, done this study and see that the active disease also affect the result of IGRA. So here we can see that active disease then can most of the active disease, like 27% here, has a indeterminate result. So means that maybe we have to be careful to use the IGRA to diagnose our latent TB in lupus patient with the active disease. So based on that, the WHO did not support to use the IGRA to diagnose the active, but maybe we can use in latent, but maybe not in the active disease patient. So the problem for management SLE, TB patient in SLE has a problem like how to diagnose. We also get a problem with the treatment, or also the medicine itself. It's a problem to our patient, and most of that, the mortality also increased by the infection of tuberculosis in our lupus patient. Our cohorts show that 10% die during the time when they diagnose TB. So this is the problem. So I would like to quote the old paper, this by Professor Feng from Singapore. They did the study of tuberculosis from year 1963, but this wisely that he recommend any prolonged febrile episode, cough, sputum, or dyspnea and weight loss should be viewed with suspicion, and unexplained pulmonary infiltrate or lymphadenopathy, pleural effusion, or ascites, you should go further aggressively, try to look for any kind of infection, especially tuberculosis. So the end of my outline is it possible that we use the INH prophylaxis to decrease the risk for the tuberculosis? Based on the guide from US or Canadian, they mentioned that if you use prednisolone more than 15 milligrams per day for 2 or 4 weeks with the patient with TST positive, then you should provide them with a prophylaxis INH. And another study showed that providing INH to the patient can decrease the tuberculosis to 70%. And also another study in India showed that providing the INH prophylaxis can decrease the prevalence of tuberculosis from 11% to 2%. However, there is a risk for hepatotoxicity that we should consider for this treatment. But this prophylaxis still controversial due to the single drug prophylaxis in high-risk SLE patient will maybe can lead to drug resistance according to some experts. Then BCG immunization, and as we are aware that is already given for us in endemic country during our child baby born life, then this this BCG is a live attenuated bovine bacillus, so it will not recommended to our lupus patient because this is the live vaccine. Then,
excuse me, sorry, Dr. Lani.
Yes.
3 minutes left.
Okay, my last. And then this is the last present paper from the Asia Pacific lupus group. And then they recommended that if you want to start the immunosuppression to lupus patient, you should rule out the active tuberculosis. Then, but however, screen for the latent is not routinely recommended. This is not because not routinely recommended. It's not because of the no use, but because there is lack of the evidence. So we did also the systematic literature review here, then found out there is no enough study to prove that this increase the risk if you use the TPT prophylaxis for our lupus patient. So our student Jessica, I would like to show here, she did some literature review also to look for the factors that affecting the outcome of the prophylaxis, and she concluded that TB prophylaxis is important due to higher benefit than risk seen in the study, and may decrease the risk of mortality of SLE patient with tuberculosis. I will not show all, but just wait that we will soon hopefully can publish this literature review. So for that, I would like to let you know that we proposed the study as a INH prophylaxis study to see the efficacy and safety. This is called the SLE study. We proposed this to the eAsia. Hopefully this can be funded by eAsia. This is the collaboration between the University of Pajajaran, University of Santo Thomas, as well as Keio University, Tokyo, Japan. For that, I would like to end my talk to show you this education of patient is important. We have published 2 books with Professor Navara, Hope for the Butterfly. And for you in Indonesia, you can always free download our recommendation for lupus treatment to our website www.rheumatology.or.id. So for this, I would summary the relationship between TB and SLE is complex and may be mutually confounding, but a diagnosis and management of TB infection in SLE poses a special challenge in TB, especially in endemic country. So with that, I would like to thank you all, my colleague, and also our young member in Lupus Study Group, Immunology Study Center, University Pajajaran, Bandung, young and full of spirit. Thank you very much. Thank you, Dr. Atik.